Hey everyone, so in this lecture we'll be covering the management part of disc displacement with reduction and disc displacement without reduction. Now we'll be talking about arthrocentesis and the surgical management in a different lecture. In this lecture we'll be covering the conservative management. So the definitive management is to re-establish the normal condyle disc relationship, and to do that we use a anterior repositioning splint. Now this splint, it basically places the mandible in a new protrusive position with the help of indentations and ramp on the occluding surface. Okay, so now we have understood that the anterior repositioning appliance, by placing the mandible in a more anterior forward position, it eliminates the clicking and it establishes a more therapeutic position between the condyle and the disc. So now the next question is, does the anterior repositioning appliance actually recapture the disc? The answer is it does not. It does not permanently recapture the disc. What it causes is adaptation of the retrodiscal tissue to the condylar position, which leads to loading without pain. So what actually is happening is that the retrodiscal tissue, it gets remodeled. The joint becomes a painless joint. However, clicking might still happen. So the retrodiscal tissue will ultimately become fibrotic and avascular. Okay, so now the next question is, how long should you wear a anterior repositioning appliance? So earlier it was thought that it should be worn 24 hours a day for at least 3 to 6 months. But now the new evidence suggests that you should not wear it all the time, as the continuous usage can lead to a posterior open bite. So instead, you should wear it only at night, and over time, when there is improvement in symptoms, there should be a gradual weaning of it. So the answer is that it should be worn only at night. Daytime usage is not required because continuous usage can lead to posterior open bite, and after a period of 3 months, when there is improvement in the symptoms, there should be a gradual weaning of its usage. Okay, now that we have discussed disc displacement with reduction, we'll now come on to disc displacement without reduction. Now, the first foremost point is that an anterior repositioning appliance is contraindicated in disc displacement without reduction, as it only aggravates the problem. So the initial therapy for disc displacement without reduction is manual manipulation to recapture the disc. Now, this manual manipulation is generally more successful if the patient is experiencing the first episode of locking, or if the locking period has been for a week or less. Patients with a long history of intermittent locking are generally going to present with morphological changes to the disc in which this reduction cannot be performed. Now, the technique of this manual disc reduction is that you put your left hand on the cranium. The right hand, it pushes downward on the mandibular second molar, a downward force, and an upward force on the chin. So with this force, downward force and the upward force, while stabilizing the cranium, we cause the mandible to distract. Now, once this distraction has happened, the same distractive force is applied for 20 to 30 seconds while the patient relaxes. Now, if the disc has been reduced, the normal range of movement around 48 mm will be possible. Now, immediately after you have achieved the reduction, it is advisable for the patient to wear an anterior repositioning appliance continuously for several days before beginning the nighttime use. Now, this appliance helps in the disc reassuming its normal shape. Now, the next question is, what if there is a failure to reduce the disc? So that means that the disc morphology has changed and the disc displacement has become permanent. So if the disc displacement has become permanent, then we have to move on to supportive therapies and the last aggressive option, which are the surgical options. So I'll be discussing those options in a separate video. And with that, we have finished the management part of disc displacement with reduction and without reduction.